Alrighty, so thanks for coming along to our First Aid 101 session. We have Peter who will be presenting this morning for you all. Bit of an overview really with first aid, and you'll soon see why it's so important to learn. And if you guys do decide to continue on with your learning, we do run CPR level 1 and level 2 first aid. We're just waiting for room availability to open up with the university before we start advertising those dates. But if you are interested, you can either send me an email and go on our waiting list, or just keep an eye on our website. We should have those dates and things up in the next couple of weeks. So I'll pass over to Peter.
All right, thanks, Melissa. Hello, I'm waving. Are you waving? Can I see everyone? Maris, hello. Tahani, hello. Can you guys see me? People are nodding their heads. Good for you. All right. Well, Melissa, thanks for that. I guess one of the good things about first aid is that you don't have to know a lot to be able to do a lot. I mean, people that do the most basic first aid courses can be really beneficial if you need to do CPR or put a bandage on someone or help someone with an EpiPen. We try not to teach things that are too hard, because then it's, a case you might forget to do something. If you've got to remember 10 things to do in first aid, then often you might not remember all of them. So one of the things that we've tried to do in most of the courses is to simplify it a little bit, just to make sure that you do the most basic beneficial things to people that have potentially got a good outcome. Now, I'm a paramedic by trade. I started working in ambulance back in the 1980s, and there's been so many changes in ambulance, but you know what, the basics of it are still the same. CPR is still basically CPR. We've got lots more bits of equipment that we can play with, but at the end of the day, when you're managing a situation where you've got a collapsed person, you don't have to have an expensive first aid kit. You don't have to have oxygen and all sorts of things. The two most important things ever considered are your head and your hands in terms of first aid. All right, so I've got about 4 topics that we're going to talk about, and we've just called this First Aid 101. It's really not an accredited course, but as I said before, I'm going to talk through the basics of these 4 items. Now, hopefully you can see the screen in front of you. If you can see the screen, just nod your head. Okay, Melissa, thank you for nodding your head. Maris, can you see the screen there? Good for you. All right, lovely. But thumbs up to you also. That proves that we're real time, and you know. So, and as I said to Melissa, you might see a cat tail come across here from time to time. Don't worry about that. Don't be alarmed. That's just normal course of action in my little office here. So 4 specific things we're going to talk about today. We're going to talk about CPR, which is probably the most vital thing you can ever do in first aid. We're going to talk about anaphylaxis and management of significant allergies, control of bleeding, which is the most common thing that we can do in first aid. And also there's been some changes over the last few years into how we manage a snake bite. So we have a very simple philosophy in snake bite management nowadays, which has proven to be very effective. All right, so away we go. Now, I'm showing you the harder slides first, just to get them out of the way. Looks a little bit more complicated than what it is. There are 4 things that we always try and cover in a person who's collapsed. The most important thing, which is the first circle, is calling for help as soon as you can. So years ago, we used to have different numbers for calling for police, fire and ambulance. It's now all the same number. It's just 000. You can dial 000 even if you're not in your own mobile phone coverage area. I'm with Optus on my phone here. If I'm out of my Optus area, then I can still dial 000. If my phone says emergency only or no signal or SOS only, I can still dial 000. I might not be in the Optus range, but I might be in the range of Telstra or Vodafone or 3G or any of the other providers, so you can still call 000. Whilst we're talking about phones, your phones have got some pretty cool features. If you have an iPhone, if I find a person collapsed, one of the first things that I do, apart from checking if they need CPR, is I pick up their phone, I push the 2 outside buttons on it, and that brings up the emergency screen. So from this screen on their phone, I can dial for an ambulance. I can push the button that says medical ID, and if they have filled information in their medical ID section on their phone, I can read all about them. If they've had a history of a stroke or diabetes or blood pressure, generally, if people are nice and they've put it into their phone, then I can read it. It works pretty well for, it works on Apple iPhones, I think the last 4 or 5 versions. And I know that the Samsung Galaxy has got similar processors. You can do a quick Google search on your phone and figure out the emergency capabilities. Whilst we're talking about phones, there are a bunch of apps you can download that can be supportive. You can download an app that allows you to find the closest first aider to where you are. You can download an app that finds the closest defibrillator. One of the other cool ones that I've got on my phone, which I'll just quickly show you, actually I'll show you 2 of them. I have an app which is called Emergency Plus. Now, it's probably back to front, don't worry about that. It's an app that has a map on it that helps you see where you are and a shortcut for calling 000 as well. So it's called Emergency Plus. It's pretty handy if you're driving somewhere and you're not sure of the name of the road and you come across an accident, because the map can tell you where you are. It's also got your latitude and longitude. You can read that out to the operator, and the operator will, tell you where you are, basically. So that's a pretty good function. What else have I got on my phone? I've got a thing called heart rate. Now, all this is, it's just a way that I can check a person's pulse. All I do is I push the start button on the front. It turns the light on at the back. You just put your finger on the light at the back. I might not be able to do it because I've got the cover on the phone. It detects the person's pulse and it tells me what their heart rate is. So that's pretty good. If you've got someone in your family or circle that has to have their heart rate in a certain range, then rather than trying to feel for pulses on people, you can actually download that onto your phone. It's called Heart Rate Pro. It's free on the App Store. All right. Makes sense so far? Not if you're good. Melissa, is that tea or coffee? One of those? Good. All right.
Coffee.
Now, the next element there is early CPR. It's very simple. The quicker you can start CPR, the more beneficial it's going to be for a person. If you had a 10-minute discussion about who's going to do it first, that's not good for the patient. We used to have a lot of emphasis on doing the breaths to a person first, but that is no longer the case. The bigger emphasis is on the chest compressions. So we're going to talk about that when we get into our primary survey. The third element is the use of a defibrillator. I come across so many people that find it hard to say the word defibrillator. Can you all say the word defibrillator? Maris, can you say defibrillator? Yeah. Kat, defibrillator. You can all say that. Good for you. All right. Or defib. Defib works just as well for you. A defibrillator basically increases a person's chance of survival if they've got a particular type of heart attack. The out-of-hospital survival rate for CPR, unfortunately, isn't as big as we'd like. It's less than 10%. But if you've got a defibrillator in use when you're doing CPR, it actually increases the chance of survival, basically. If the heart is in a particular rhythm, Your heart normally goes straight line, squiggle, straight line, squiggle, straight line, squiggle. That's your pulse rate. If your heart is going like this, just a bizarre squiggle across the page, then that's called fibrillation. That person needs the defibrillator to actually help the heart to restart back into a normal rhythm. So they're handy to have. All right, so they're the first three elements of our chain of survival. The first one is, what do we do for someone when resuscitation has worked? They've started to breathe, they've started to move. We need to continue to look after them. Now, an unconscious person that's breathing has to be on their side. That's the bottom line, just to help to protect the airway and help with their breathing. If a person has collapsed but they don't need CPR, then we should still be assisting them. A person who's asthmatic, okay, probably needs their Ventolin. A person who's had a heart attack might need to take their own tablets or whatever the doctor has prescribed for them. So we don't just brush ourselves off and walk away. We have to do something to continue to provide assistance to that person. All right. Now, when you have an unconscious person in front of you, these are the 7 things we'd like you to do. DRS ABCD. It used to be called Dr. ABC back in the olden days, but we've added the S to send for help and also the D, just to remind us that we have to do some form of defibrillation if we've got the defibrillator present. So, quick chat about each of these things. Firstly, check for dangers. You are more important than the patient, okay? So you should never put yourself into danger when you're assessing a collapsed person. So what do we look for? We look for electricity, we look for gas, we look for dangerous things, we look for anything that might stop us from, doing good things for the patient. Are you all calm people? If you're a calm person, nod your head. Are you a calm people? Maris, you're not sure? I bet you can be calm in an emergency situation. Good for you. All right. The key point when you're assessing a collapsed person is try and stay calm enough so that you can have a look around the area just to make sure that there's nothing that's going to impact on you. The second thing, try and get a response from the patient. Now, the phrase that we use is talk and touch. It used to be shake and shout, but that had visions of you shaking the stuffing out of a patient. We don't want you to do that. Hand on the shoulder, give it a bit of a shake, talk to them, see if you can get any sort of voluntary response. If you get anything, good. That person doesn't need CPR. If they're moving, coughing, crying, then that's kind of okay. It means that they've got a heartbeat, they've got a pulse, they've got some activity happening there. Now, you've still got to check them out just to try and figure out why they're on the floor, but that's basically the end of your CPR process. All right. Sending for help. In every situation where a person is collapsed for an unknown cause, call for an ambulance. It can always be cancelled. If you find out that it's something that's completely different, they might have been asleep or pretending or something that's an expected part of their lives, you can always ring 000 back and tell them of the change in the patient's condition. But it's good to get the ambulance on the way first. All right. Checking for an airway is as simple as looking in the mouth of the patient. That's it. Nothing too hard about that. The easiest way to check an airway is to open up the mouth and see whether there's anything in it. Now, this is particularly important for little kids because what do little kids put in their mouths? Pretty much anything that will fit. Okay, so that's why we need to make sure that you have a good look in the mouth and remove anything that's there. How do we get it out? Roll the person onto the side, tilt the head back a little bit, and then scoop out whatever it is that you find in there. Wash your hands afterwards. All right. Next element is to check for breathing. It can be as simple as looking at the patient and observing whether that person has got chest movement. If the chest is moving and you can feel the breathing on your hand or on the side of your cheek, good for you and good for them. All unconscious people that are breathing have to be on their side, regardless of the injuries. So as best you can, one hand on the shoulder, one hand on their hip, push them over until they're lying on their side, and then just tilt the head back a little bit. It's a life-saving maneuver for all unconscious people to put them onto their side. Okay, so let's say we've got an unconscious person, they're on the floor, you check for dangers, they're not responding, you've called for 000, you've looked in the mouth and you've checked for breathing, and goodness gracious me, they're not breathing. Okay, next thing to do is to do hand compressions on the chest. Now, years ago, we used to have different ways of doing it for adults and children and infants. We used to have different rates, speeds, depths. The ratio was a little bit different. All of that's basically gone out the window. There are basically three things that you have to remember. You've got to put your hands in the center of the chest, there, right at the bottom half of the breastbone itself. You need to push down 1/3 of the chest depth. So if I've got a skinny little person that's only about that wide, then I need to estimate 1/3 of what their chest depth is. If I'm trying to do CPR to a larger person, then obviously I need to push down a further distance in the middle of the chest. The third thing to remember is how fast we do it. Between 1 and 2 compressions per second. Songs to keep in mind whilst you're doing this. Staying alive, heart, 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 staying alive, staying alive. If you can't remember that one, row, row, row your boat. Happy birthday to you. Don't sing that one out loud if you're ever doing CPR. That just wouldn't be good. So as long as you're doing between 1 and 2 compressions per second, and it's the same speed for everybody, children, infants, adults, it's exactly the same. Now, their normal heart rate is usually a little bit faster, children's and infants, but as long as we maintain that staying alive rhythm, then we're giving the heart the best chance to actually restart by itself. Now, to get the right number of hands and fingers and things, the rule that we have, which is also not a hard and fast rule. If I'm doing CPR to an adult, let me stand up for a second. Here I am here, one hand in the center of the chest, other hand on top, or I can grab the wrist, I can interlock the fingers. It doesn't matter. As long as I've got 2 hands on the lower half of the chest bone, then we're doing what we need to do. If it's a smaller person, such as a child, 1 hand. You'll achieve 1/3 of the chest depth with 1 hand. If it's an infant, 2 fingers or 2 thumbs. Grab them around the waist, put the thumbs in the middle of the chest and push down. And we want you to continue to do compressions. Now, you can do some breaths if you feel comfortable with doing it. The ratio, if you're doing compressions and breathing, is 30 to 2. 30 compressions, 2 breaths. For an adult, it is mouth to mouth, which means you have to tilt the person's head back, pinch the nose closed, open up the mouth, and then put your mouth over the mouth of the patient. It's good to have some sort of barrier protection when you do this. So you can use a handkerchief, you can use, I could use a sleeve, I could use a collar, I could use a towel, anything that's going to give me a little barrier, a bit of barrier protection between me and the patient is a good thing. Can you do touchy-feely mouth to mouth on people? Sure, if you want to. Let me just ask, I want to see a show of hands here. Who would do mouth to mouth on someone in their own family? I would. All right. Who would do mouth to mouth on a child? I would. Yep. Who would do mouth to mouth on the man that lives next door to you? Well done, Kat. Good for you. All right. Do you live next door to me? Because that would be good. Okay. So it's a personal choice. As I said before, in an emergency, it's good to stay calm, but your adrenaline is probably running. You're probably going to do things that you might not think that you were capable of doing. There are some risks inherent in doing mouth-to-mouth if the patient has got blood-borne contaminants in their system. They might have facial fractures. So it's really your choice as to whether you actually want to do the mouth-to-mouth or not. There are barrier protection devices that you can buy. You can buy face shields, which is just a little piece of plastic, and it's got a valve in the middle. You can actually buy a fitted face mask that has a valve on the end of it that you put your mouth on. There's several different types of delivery systems. Have I actually done mouth-to-mouth to people? Yes, I have. In situations where I haven't had any first aid equipment, I've been shopping or at the movies or something. I mean, it doesn't happen very frequently. It's happened to me twice. So I don't know, maybe I'm a bearer of, bad things happening. I don't know. All right. We all good so far? Nod of the head. Thank you. All right. And if you've got a defibrillator there, you need to get someone else to go and get it for you. If you're doing CPR on someone, you shouldn't be the one that actually goes to get the defibrillator, because that's detrimental for the patient. If I walk away from the patient to go over there to get the defibrillator, then that little bit of blood pressure that I've built up in the patient when I've been doing compressions, if I stop those compressions completely, then it's going to drop back down again. So you have to continue compressions and get someone else to go and get the defibrillator. Now, by law, all defibrillators have to have instructions on them. They have two buttons, a green one to turn it on and an orange one to shock the patient if needed. So all of the defibrillators, the pads that go on the chest, have little pictures on them as to where they need to go. So where do they go? Oh, right shoulder. I'm actually putting this on my left hand, but because the picture's reduced, it's hard to remember. So right shoulder and then underneath the left armpit. And that's where the pads go for an adult. Now, clothing doesn't have to be completely removed. I could open up the shirt, lift the shirt up a little bit. If there are straps and things in the way, I might just have to move a strap just to get good adhesion with the pads. But you don't have to be, have the patient completely remove their clothes. If the chest is wet, if I've just pulled the person out of a swimming pool or a spa or a bath, I need to dry the chest, just because the current might be interrupted if the chest is wet. So you need to make sure the chest is dry and that you're not touching the patient when the defibrillator is working. All right, that makes sense? Yes? All right, good. Okay, so just to summarise this, dangers, we look for yourself, bystanders and obviously the patient, but you notice the word yourself is right at the front. For response, talk and touch, hand on the shoulder to see whether you can wake them up at all. The number to call is 000. Now, on the screen where it says 112, that was a number that you could dial if you didn't have a cellular phone that will contact or make contact with any of the providers. So if you've got an older model phone, then you can dial 112. Another important number to remember is the number for poisons information. Does anyone remember what it is? If you remember it, nod your head. Okay. Is it 131166? Is that it? No, that's Pizza Hut. Don't ring that one. Okay. 131126 is the number for poisons information. Or if you don't remember what the number is, call 000. They'll put you through. Okay. Open the airway. We talked about that. Check for breathing by look, listening and feeling to feel if we can, notice any breathing. Compressions. This is what we talked about. 30 to 2, pushing down 1/3 at a rate of between 1 and 2 compressions per second, or if you're good at math, 100 to 120 compressions per minute. Close enough is good enough. You don't have to exactly replicate the person's normal pulse rate, but between 1 and 2 per second will be good enough. And the last element there, defibrillation, which we talked about. Okay. Now, this page looks a bit more complicated than it is. The Australian Resuscitation Council, which is the governing body for all things first aid, has said that we don't have to do the mouth-to-mouth component whilst we're still under the COVID threat. So the left-hand side is for what I would call normal CPR. So there you see your DRS, A, B, C, D. On the right-hand side, where we have to wear masks in the local area, which is us at the moment. So the right-hand column, it says response, send for help, open the airway, breathing. It says that you look at the patient, but you don't have to get down really close to listen or feel. That puts you into very close proximity with the patient. And if they do have COVID, then it increases the risk. So at the moment, we're just looking at the patient to see if we can see them breathing. And if not, we start CPR, but it says chest compressions only. Okay, we don't do breathing to people under the COVID landscape that we're in at the moment. It also says consider placing a light cloth or clothing over the person's mouth and nose so that when you're doing compression, if they're shooting little bits of air out, then they're not going to spit on you, or, you know, it's not going to increase the risk to them. Okay, so this is the current philosophy for CPR, given the current COVID landscape that we're in. All right, make sense? All good? All right. Let's move on a bit. What do we do for someone who's unconscious? We talked about this a little bit before. If you're unconscious and breathing, you need to be rolled onto your side, regardless of the injuries. Often we don't know what's caused a person to become unconscious. It could be just a medical problem. They could be asthmatic. They could have had a stroke. They could have had a heart attack. Often we don't know. Often paramedics don't know. We often take people to hospital who are unconscious. And then the triage nurse in the emergency centre comes up to us and they say, oh, what's wrong with the patient? And we say, don't know, don't have a clue. Because often we don't know what's causing a person to be unconscious. We treat them all the same. Roll them on the side, tilt their head back, monitor their breathing, and then wait for the next level of care. So it does give you on this screen a few steps into how to do that. I don't know how well you're going to be able to see this, but if let's say I'm unconscious on the ground, pretend I'm lying down. What I normally do is I put one arm out, one arm to the shoulder, lift up the person's knee, and then I basically push them over on the hip and shoulder until they're lying on their side, and then I tilt the head back a bit. Now, if I had a broken arm, here's my arm and my leg down here. If I had a broken arm and a broken leg, you're not going to roll me on that side. You're going to roll me on the other side so that you're not increasing any injuries to people. All right. Does that make sense? Good? All right. Now, we've got a few other little topics that we're going to have a quick chat about. I thought about bringing in lots of little props and aids and things, but then I remembered, no, we're treating this as simply as possible. So the only thing that I've actually got with me is a compressive bandage. Now, I can pretty much manage any external bleed using one of these. I also like to have some sort of cloth pad. These are makeup removers. I've got about 50 bags of these because if I've got a person that's got an injury, a cut, I put these on first and then I put the compressive bandage over the top. If I was just to put this bandage over a cut, it's actually porous. It's got lots of little holes in it. You can you know, you should be able to see through it, and blood will just come through this. So that's why you've always got to have something that's fairly coarse, fairly dense to put on, just to help with clotting. That's why Band-Aids have got that little cloth piece in the middle. Okay, so where do I get these from? Chemist Warehouse, 95 cents for a bag of, I think, 80 of them. Buy 2, and they're really, really handy. Are they absolutely sterile? No, they're not. But you know what? Neither is your skin. So in an emergency situation, these will do quite well. Now, on the screen, it shows you that if you've got a penetrating injury, then you need to put some sort of bandage around whatever the impaled object is, and you don't pull it out. That's how Steve Irwin died. He had a stingray barb in the centre of the chest, and the belief is that he pulled it out. He probably said crikey when he did it, but he bled to death very quickly because they didn't do any sort of constrictive bandage to hold the thing in place. If I had something stuck in my chest, I could get a bandage like this, make one loop around my hand to make a circle, and then I could put it over whatever the object is. If I had this here, I would put this over here, pull the 2 ends tight so it's holding it, and then with one tail I'll wrap that way, with the other tail I'll wrap that way, as much as I can to hold the object in place. All right. A nosebleed. If you've got a significant nosebleed, so I'm just throwing things around the office here. If you've got a significant nosebleed, then you need to pinch the bottom part of the nose, not the top bit. I can pinch the bone at the top and still breathe through my nose. It's got to be the bit at the bottom, and I've got to tilt my head forwards as that guy is doing. If I tilt my head back for a significant nosebleed, then all the blood's going to run down the back of the throat, and we don't want that to happen. Okay, the picture on the bottom left, the wrist injury, all they've done is they've applied direct pressure. Okay, so compressive bandages, these things, fabulous, plenty of stretch, plenty of give. I can basically put one of those anywhere on the body. The head, the waist, the chin, even the throat. It's not going to completely cut off circulation or breathing, but these are fabulous. The other thing that we can do for people that have got a significant injury, okay, I put the bandage on here. If the blood starts to come through, here's me pretending to have blood spurting out of my wrist, is I put another bandage on top of it. If the bandage is still not stopping the blood flow, I can elevate it. If I have a hand up here, and what this is doing is this is reducing blood flow. So it's dropping the blood pressure in my hand. It's going to help to reduce the blood loss. All right. Make sense? Good. All right. Thank you. What's the cheery picture up on the top right-hand side? Oh, goodness gracious me. Amputations. Do you know what the common things are that we amputate? Yeah, those things. Yep, absolutely. Fingers are by far the most common amputated part because we're always sticking in places and we've got 10 of them. So, you know, we're always getting into strife with them. What do we do with the part? If I started like this, but I ended like this, I put a compressive bandage over the stump is what it's called. What do I do with the fingers? Put them in a plastic bag, float them in cold water, not in direct contact with ice, and they need to go to hospital with the patient. Okay, so fingers are by far the most commonly amputated part. Not too many toes, I'd have to say. The only time we tend to get toes amputated, it's mostly from people mowing lawns in thongs and things like this. If you're going to mow your lawns, wear your safety thongs and not just your normal ones. So that's never a good thing. All right. Now, What are the key things we need to do? Gloves are good. We should be getting into the habit. If you've got a first aid kit of any caliber, you need to have gloves in it, okay? Because you want to make sure that you don't provide any contamination to the patient and vice versa. Also at Chemist Warehouse, you can buy boxes of, you can have vinyl gloves, you can have latex gloves, you can get 100 of them for about $8. Leave them in the glove box of your car or in the bathroom. If they get to about 12 months old and you've never used them, throw them away. There's nothing worse than trying to put on an old glove and your hand just goes straight through the end of it. So if you've got gloves, just make sure that you replace them from time to time. All right. So everything on the screen there should make sense in terms of gloves, applying a bandage firmly, putting another one over the top of it, and elevating the injured part if the bleeding is severe. All good? Good. There's that little donut bandage that I mentioned before. That's quite a complicated one. You don't have to go to that particular extent. What I do is, as I said, I just make one loop around my hand so that it makes a circle. I put it over whatever the impaled object is, and then I just pull the two ends tight. So if you've got time, you can certainly make a circle, and then with the tail of the bandage, you just wind it through. You keep going and you keep going and you keep going till you end up with a nice little crown. But if it's a significant injury, I wouldn't waste time with doing that. I would just make that one loop like that, and that's good enough in an emergency. All right. What's that little guy's problem on the right-hand side there? Goodness me, I think he's having an allergic reaction to something. So that's quite a significant set of signs and symptoms. He's probably got all of the signs and symptoms of an anaphylactic reaction. Now, anaphylaxis is a full body reaction. So you can see the swelling to the face, the lips, see that on his chest, he's got those little welts, those little sort of hivey type things. They're two of the three significant signs of an allergic reaction. The other one would be, which we can't really see, shortness of breath, finding it hard to breathe. So generally, you only find out you're allergic to something after it's happened to you. When do you know you're allergic to bee stings? When the bee stung you. When do you know you're allergic to peanuts? When you've had them. When do you know you're allergic to penicillin? When you've gone to the doctor and he's given you penicillin. So that's why we have to be aware of the significant symptoms of an allergic reaction. And that's where one of these things might come into play. This is an EpiPen, which has adrenaline in it. I think most people have seen these in some, format before, but this is one of the most life-saving pieces of equipment you can ever have, especially in terms of allergic reactions. So very quickly, it has a blue top, it has an orange bottom, the blue end goes up, the orange end goes down, blue to the thigh, blue to the sky, orange to the thigh. I nearly got that completely wrong. So the blue end goes up. Where do we jab someone with this? In the side of the thigh, because that allows for the quickest release of adrenaline into the body tissues, and that's where we want it to do. Who's seen the movie Pulp Fiction? Good. Uma Thurman, John Travolta. Uma Thurman's unconscious on the ground. John Travolta gets an adrenaline needle and sticks it straight in her chest, and she has virtually an immediate reaction. That's kind of the response that you'll get from people when you jab them in the thigh with one of these, if they're having a significant allergic reaction. If someone walked into my little office now and it looked like they were having an allergic reaction. And if they've never been prescribed one of these things before, I'm going to jab them in the leg with this. Even if they haven't been seen by a doctor, it hasn't been prescribed to them, it's still considered to be one of the safest, most effective, life-saving little things that you can have. Now, you can buy them from the chemist without a prescription. They're a little bit more expensive. I often have discussions with schools as to whether they should have a couple of spares in case a kid suddenly decides to become allergic to things. And I generally say, yes, great idea. Go to your chemist, get 1 or 2 spare EpiPens, and then while you're at it, get 1 or 2 spare Ventolin canisters as well. Just in case a child has an asthma attack and they don't have their own medication, good to have a spare. Ventolin is also something that you could administer to someone without a prescription. If they're having their very first asthma attack and you've got Ventolin that you can share, let them have a few puffs with it, see how it works. All right, we good? Good. All right. So there's your signs and symptoms on the screen for anaphylaxis. What's the bottom one? Death may occur. Well, that's a thing. It is possible. Now, on the right-hand side, we have 2 different types of delivery systems. We have got the green one for little children and the yellow one for adults. Generally, preschoolers have the green ones, and basically that's half the dose of the adult one. It's still the side of the thigh. It'll go through clothing. You don't have to have direct skin contact. What you need to do is just quickly check that there's no car keys or mobile phones or Tamagotchis in their pocket. I don't think people have Tamagotchis anymore, but it's not a bad idea to get. Kat, have you still got a Tamagotchi, have you? Goodness gracious me.
Second generation.
Sorry, say again?
A second generation, so
good
second version of it.
Oh, right. Gee, the batteries must be good in it if they've lasted this long. So good for you.
No, it's officially died, and I think I had like 5 generations on that little life. So,
okay. All right. Well, I tell you what, do me a favour. If you're walking around the street, don't have it in your side pocket, just in case you have an allergic reaction, because this won't go through the Tamagotchi. All right. Okay. Now, on the list in terms of management, lie or sit them down after you've administered the EpiPen, because people that have had that sudden rush of adrenaline into their body, it's a little bit like getting a sudden fright from a spider that suddenly appears in front of you. So it's likely to make people feel a little bit jittery, I don't know what the word is. It gives them the jitters. They might feel faint. So they need to lie down. Obviously, if they go to the end extent of going into cardiac or respiratory arrest, CPR, what can I say? The good news is we don't lose that many people to allergic reactions because of the frequency that we see these out in the general public. So it's good to have. All right. Now, show of hands, who knows the difference between a venomous snake and a non-venomous snake? Who knows the difference? Okay, don't see too many hands up there. I see a couple. Now, here's the thing. If you do know the difference between them, good for you. If you don't know the difference between them, stay away from all of them. Okay, there's no hard or fast rule about the colours, the shape of the head, whether they can climb trees, whether they can swim. You really need to know the difference between the different varieties of snakes in order to tell which ones are venomous and which ones aren't. But I tell you what, if in doubt, stay away from all of them, basically. Now, this is going to horrify some people, but you know what we used to do for snake bites back in the day? We used to cut open the site of the bite, suck out the poison, and spit it on a rock. That's what we used to do. We don't do that nowadays. John Wayne probably used to do that back in the day, for those of you that remember John Wayne. But we don't do it anymore. Now, on the screen, it has got some signs and symptoms of a snake bite. Not all snake bites leave two distinct puncture marks in the skin, and that's how TV and the movies always portray them. No, it might just be a scratch along the surface of the skin. There might be a little bit of clear fluid around it, which could be the venom that the snake tried to introduce. So if you've got a person that has any of those signs and symptoms, certainly just a change in their normal conscious level. If they suddenly develop a headache, nausea, vomiting, abdominal pain, then that's some of the key signs of a snake bite. Also, what we used to do years ago was put a tourniquet around the arm. Tourniquet is a very narrow type shoelace thing that completely cuts off circulation. We don't want to do that to snake bite victims, mainly because when you're bitten by a snake, the snake doesn't inject venom directly into the bloodstream. They're not that good a shot. They're not going to get a vein or an artery. They're going to just put it underneath the surface of the skin, and therefore it's the tissues that can actually cause movement of the venom up into the rest of the body. So if we put a compressive bandage on, as is shown in the picture there, and we keep the bitten limb down, therefore we have the best chance of actually reducing the spread of the venom up to the rest of the body. Now, where do most snake bites happen? In the leg, generally in the leg. You're trudging through the bush, you're making lots of noise. Generally, most snakes are not aggressive, but they will defend themselves. So if you come marching directly at them, then they're going to take you as a bit of a threat and they're going to have a go at you. The next common body area would be the arms. You're reaching behind the wood at the back of your old woodshed, and there's a snake happily curled up there in the warmth, and it thinks that you're a threat, and so it lashes out at you. So that's why the compressive bandages work really good on an arm and a leg, because we can get really good compression on them. If you're unlucky enough to have a snake bite in the middle of the chest or the groin or the buttocks or something, then you just need to lie down, stay still, wait for the ambulance to come. If it's a limb, such as an arm or a leg, you need to make sure that you have good bandaging over it, and then you keep the bitten limb down. If I've got my arm down here, it means that I'm reducing the flow of fluid in the tissues back into the rest of the body. If we were in New South Wales, in Sydney, we'd also be talking about funnel web spiders, because funnel webs funnel webs have got the same toxic potential as venomous snakes. So we don't get the dangerous types of spiders down here. We get redback spiders, we get whitetail spiders, we have huntsman spiders. None of them are really extremely dangerous. You can get some localized swelling and pain, but the best thing to do for those is cold water, cold running water, to help to dissipate whatever the little bit of venom they might have had of their fangs. But cold water also helps with pain and swelling. I'm sure you all know that if you get a sprained ankle, an ice pack is one of the best things that you can put on it, because it's going to help to reduce the pain and swelling to the region itself. I don't think we get too many other dangerous types of spiders down here. I think we talked about the redbacks, the whitetails. Huntsman spiders aren't really dangerous at all. We've got those little ones that come up the water spout. What are those ones? The incy-wincy spiders. I think they're okay. Had a disagreement with a girl last week. She said, no, it's called itsy-bitsy spiders. I said, no, it's incy-wincy spiders. I went to Google to check it, and I was right. She was wrong. Thank you. All right. Okay. Any questions, concerns, issues on any of those topics? Any questions at all? If you've got a question, just raise your hand, nod your head. Otherwise, we've got one more little piece of information to talk about, and then we're done. All right.
Peter,
Yes.
we've just had a question come up in the chat box. So
Yes.
Dashani just wanted to know, as well as if one got stung by a sea urchin, do we pull off the sting or not?
Yes. Make sure you got gloves on, because you don't want to be a recipient of, whatever the toxin it might have there. And then just water. Hot water is good, but I don't know who carries hot water to the beach. Then just fresh water, if you've got it, just to try and flush any toxin or any product off the skin itself. So yes, you can pull it out, but try and make sure that you've got some protection on your hand first before you do it.
Awesome, thank you.
Any other questions? All right. Now, as I said at the start, knowing first aid is good. It really is. There's nothing worse than coming up against a situation and you feel helpless because you just don't know what to do. As I said at the start, we've tried to make first aid very basic for people. Some organisations go quite deeply into how to do bandages and slings and splints and things in first aid courses. That's all fine, but they always focus on what is the simplest thing that you can do first to give the best outcome to the patient. It's the type of thing where we teach people how to do things and we kind of hope they never have to do it. Probably goes against the grain of every other training course you've ever done. You learn how to do something so that you can do it frequently and as well as you can. But with first aid, it's just that little bit different. I can't tell you how gratifying it is to have done first aid to someone and it's worked, and you get a nice little card or a thank you, or you just feel good about being able to do something that is positive for people. Okay. Now, on the screen, Deacon's got heaps of other courses available. I'm sure there's an online portal or way that you can explore the different types of courses that are available. So, as I said, it's good to know a little bit because it might be really beneficial for a patient in the long run. All right. I'm done.
Awesome. Thank you so much, Peter. And yeah, as I said, guys, just keep an eye on the DUSA website for course dates. I think we do have a mental health first aid date up at the moment, and that course will be delivered online. So there'll be some pre-course work you need to do through an online portal, and then the actual class sessions will be via Zoom.
Peter, before you go, I did just want to thank you on behalf of the student representatives and council. Thank you so much for your time. It's been really, really great.
My pleasure. I've had a secret cup of tea sitting by my side the whole time. Oh, you've had one too there, so good for you. Hope it all goes well for whatever courses or anything that you might be doing there.
Wonderful.
I did just have the one question. You've got displayed on the screen there, workplace level 2. Do we have to do level 1 before that, or can we just go straight into level 2?
Straight into level 2.
Awesome.
Sorry, Melissa, if I'm stealing your thunder here.
No.
There are several levels of first aid that you can do. At the very least, you can do CPR. We do have a thing which is similar to the level 1 first aid course, but I got to tell you, not too many places do that. The level 2 course also includes CPR, but it talks about basically the things that we talked about today: bleeding, fractures, anaphylaxis. It goes into choking, goes into seizures and burns. It goes into a little bit more detail. The next level above that is an educational first aid course. It contains everything that's in CPR, level 2, but the educational level also has a bit more information on anaphylaxis, asthma, legal requirements in a school situation, report forms and things. So it's probably the next level, but no, you don't have to do the preceding ones first because they're all covered.
Cool. Thank you.
You're welcome.
Awesome. All right, well, I'll close our session off, but thanks again, and thanks everyone for attending.
Thanks, everyone.
Thanks. Bye.
Bye. See ya.